Would you like to learn about the causes and the pathophysiology of heart failure? It's coming up next. This is Raj
and Niya with your favorite USMLE channel, where we help you gain in-depth understanding of the high-yield USMLE topics and score phenomenal on the steps.
We're teaching medical content for all steps using our own personally crafted mind maps and algorithm that's going to make concepts stick.
What you can expect in our videos is a lot of integration, as well as getting a clinical perspective of what's truly important to learn.
Hope you enjoy this video.
Please subscribe to our channel if you haven't already, and hit the bell button to receive notifications once we upload new videos.
Thank you for watching. Heart failure. Heart failure is basically divided into systolic heart failure and diastolic heart failure. The key difference between systolic heart failure versus diastolic heart failure is this. If you look at the heart picture over here, you see that the ventricles are very stretched out. Right here it looks very stretched out. All right, so which means your capacity of volume that could be filled in the heart is a lot, but the problem is when you stretch something too much, it cannot pump. Think about a rubber band. If you pull a rubber band a lot, after a point it's never going to recoil. Same thing happens to the heart, and therefore I want you to focus on this word, eccentric. The sarcomeres, which is essentially the units within the muscle, is actually arranged in an eccentric pattern, essentially meaning in a straight line like this. This is known as eccentric. So in systolic heart failure, you have an eccentric arrangement of sarcomeres. Your ventricles are stretched out, the volume is full, but the heart fails to pump. Because why? You've stretched your rubber band too much that it does not recoil any longer. Next, diastolic heart failure. The pathophysiology is a little different. If you look at diastolic heart failure, I want you to focus on the ventricular size. It's nice and thick, nice and muscular. Why is it so nice and muscular? It's because of this word right here. It's called concentric. Again, the sarcomeres, which are the units within the muscle, are arranged in a concentric pattern. They're arranged parallelly like this. That makes the muscle nice and thick. So the muscle has no problem contracting. But what is the problem? Look at your chamber size. Look at the amount of volume that you could fill out into this small little chamber. It's very little. So the problem is essentially with the filling of the heart. So diastolic filling is affected, and therefore we call it as a diastolic heart failure. Systolic heart failure. What are the causes? Let's talk about this. So number one, I want you to focus up here. 95% of the time why somebody gets a dilated cardiomyopathy or a systolic heart failure are because of hypertension, coronary artery disease, and valvular heart disease. Think about it like this. The concept is what makes you remember things. So anything that's going to cause your heart to get stretched out will cause a systolic heart failure. If you have high blood pressure, your heart's pumping. Initially it'll get nice and muscular, but after a point it's going to get so stretched out that you will end up getting dilated cardiomyopathy. Number two, coronary artery disease. Imagine if somebody has a myocardial infarction. A part of the heart muscle is actually dead. It is dead, which means it will no longer recover. If you trace back your molecular biology, you'll understand that the cardiac muscle cells and the nerve cells are actually always going to be in phase G0, which means if they die, they can never ever come back. That's the reason why it's so important to treat MIs and strokes within a certain time limit. So if you have a myocardial infarction due to coronary artery disease, you will end up getting a dilated cardiomyopathy. Pretty straightforward. Number three, think about valvular heart disease. Think about aortic stenosis. If you have a blockage in your aortic valve and your left ventricle is pumping, after a point there's going to be such high pressure, it's going to cause your ventricle to stretch out. What about the regurgitations? Aortic regurgitation, mitral regurgitation. All these things is bringing in a lot of volume into your ventricles and essentially causing a stretch, and over time it's going to cause dilated cardiomyopathy. Very good. So these are your three most important causes which contributes to 95% of dilated cardiomyopathy. Now the 5% which the USMLE loves is the rest of them. Number one, alcohol. Why does alcohol give you a dilated cardiomyopathy? It comes down to biochemistry. If you trace back biochemistry, think about it. If you want to metabolize glucose and produce energy, you need glycolysis, TCA cycle, and eventually electron transport chain. So does any of these enzymes present in this pathway require thiamine? Yes, they do. Pyruvate dehydrogenase enzyme requires thiamine. Alpha ketoglutarate dehydrogenase requires thiamine. So if you look at it, in order for you to go from pyruvate to acetyl-CoA, you require the enzyme pyruvate dehydrogenase, which means you will not enter the TCA cycle if you're deficient in thiamine. Alright, and if you do not have thiamine, what about your alpha ketoglutarate dehydrogenase, which is part of your TCA cycle, will also not work. So essentially my point is, if you drink alcohol, they have less thiamine. Why? Because they do not eat enough thiamine, and alcohol also inhibits the absorption of thiamine from the gut. So two reasons: decrease intake and decrease absorption. Now you have thiamine deficiency. If you have thiamine deficiency, you are going to be energy depleted because glucose cannot be metabolized to form ATP. Well, you can argue and tell me, okay, what about keto acids? Keto acids can be broken down and used to make energy. Well, do you know that the branch chain keto acid dehydrogenase enzyme for this process also requires thiamine? There you go. So you cannot use that either. So my point is, you are going to be so energy depleted in a person who's an alcoholic. What are the two most energy dependent organs in your body? As I said, which remains in G0 was your brain, which is your neuronal fibers, and your heart. So think about it: wet beriberi, dry beriberi. Dry beriberi is your Wernicke-Korsakoff psychosis and peripheral neuropathy. Why? Nerves and brain. Simple. What about wet beriberi? It is dilated cardiomyopathy. There you go. Now you understood it perfectly. Alright, then you got cocaine. Now cocaine causes vasospasm of the coronary vessels and can cause myocardial infarction. So these are all postulated theories as to why it would give you a dilated cardiomyopathy. Coxsackie B, again, it's not well understood. There's a viral damage as well as an immunologic reason as to how your body tries to fight the infection, and all of this leads to a dilated cardiomyopathy. Chagas disease, which is spread by your kissing bug and caused by the organism Trypanosoma cruzi. Apart from causing dilated cardiomyopathy, it also gives you a dilated esophagus. Alright. Hemochromatosis, this is a condition where you have too much iron absorption. I'll be covering this as to how this happens in the section of hematology, so stay tuned for that. Either way, you should know if you have too much iron, it's going to get deposited into your heart muscle, and this can give you a dilated cardiomyopathy, but also it can give you an infiltrative cardiomyopathy, which is gonna essentially result in a more diastolic heart failure. So it can cause both. Number 6 you have here is peripartum cardiomyopathy. So peripartum cardiomyopathy normally happens about 1 month prior to delivery and about 5 months after delivery. Within this time span, it is an immunologic reason why the patient ends up getting a peripartum cardiomyopathy. Important and fun facts: the treatment for heart failure with peripartum cardiomyopathy remains the same. The only difference is you cannot use your ACE inhibitors, ARBs, or angiotensin receptor neprilysin inhibitors due to its teratogenic effects. Alright, and let's go over here and you will see that there's hypothyroidism as well as hyperthyroid. Both of them can give you a dilated cardiomyopathy. Drugs, this is a very important question. What drugs can give you dilated cardiomyopathy? The big ones are your doxorubicin. Where do you use them? You will use them in the treatment of Hodgkin's lymphoma. Alright, what about the next one? Cyclophosphamide, the same drug that gives you hemorrhagic cystitis that's prevented by using Mesna, can also give you a dilated cardiomyopathy. Number 3, you have trastuzumab. The trade name is known as Herceptin. It is used for the treatment of breast cancer, which can also give you dilated cardiomyopathy. Then, like every other thing that could happen in HIV also gives you dilated cardiomyopathy. SLE can also give you dilated cardiomyopathy. And finally, you have your muscular dystrophies, which are Duchenne's and Becker's muscular dystrophy. There you go. These are all the causes of dilated cardiomyopathy. Learn them, understand them, and you'll score very well on your exam. Diastolic heart failure. Alright, as I just explained to you, diastolic heart failure is a problem with the filling of the ventricles. It's a chamber size, it's not the problem with the muscle. Alright, what are the causes? Number 1, again, as I said, majority of the time the cause is going to be hypertension. So if you have high blood pressure, imagine a muscle contracting and contracting and contracting, you will have hypertrophy of the muscle first before you end up having a dilated cardiomyopathy. So first result of hypertension is going to be hypertrophic cardiomyopathy. So that's number one. Number two, you need to know about HFrEF. It's a very interesting and a very important subject for the USMLEs. Hypertrophic obstructive cardiomyopathy. It is a genetic disorder. It's an autosomal dominant inheritance pattern. Essentially what happens is your ventricle hypertrophies to a point that it is going to cause an outflow obstruction to the flow of blood outside your ventricles. Alright, we will cover this topic separately. However, I want you to remember that HFrEF is another reason for getting a hypertrophic cardiomyopathy. Alright, now moving on to restrictive. So if you think about a diastolic heart failure, there's actually two types to it. There is a hypertrophic heart failure and you have a restrictive heart failure. The difference is, in case of hypertrophic, you're going to be having your sarcomeres arranged in a concentric pattern, whereas in restrictive your ventricle is going to be filled up with all sorts of junk. Now it's got all sorts of junk accumulating into your ventricles and it's going to cause some form of fibrosis, and therefore it's going to give you a restrictive type of cardiomyopathy. So what causes restrictive cardiomyopathy? A big disease is sarcoidosis. They love to ask you this question. They will give you an American female 30s to 40s coming in, they'll give you a chest x-ray picture and then show you some form of mediastinal lymphadenopathy. Always think about sarcoidosis, and sarcoidosis often will have hypercalcemia. That's a big one. Reason is your granulomas that's present in sarcoid is going to be producing alpha-1 hydroxylase enzyme, which causes conversion of 25 hydroxy vitamin D to the active form, which is 125 hydroxy vitamin D, and that is going to cause a lot of reabsorption of calcium and cause hypercalcemia. Number two, it will also have hypertension. Reason is because the same granulomas is going to be producing angiotensin converting enzyme. Very good. If somebody asks you what is the most accurate test for sarcoidosis, it's going to be biopsy, but there's a couple of instances where you do not need biopsy. Just the presence of certain other syndromes can actually suggest sarcoid so much so that you do not need a biopsy. You can just start treatment with prednisone. Alright, so those two syndromes are Hereford syndrome and Lofgren syndrome. Hereford syndrome, also known as a uveitis fever. Essentially the patient is going to have fever, parotid swelling, anterior uveitis and a facial nerve palsy. If you have this syndrome, it is highly suggestive of sarcoidosis and you can begin treatment right away. Number two, you're going to have Lofgren syndrome. Lofgren syndrome is composed of, or what the syndrome has is going to be mediastinal lymphadenopathy, erythema nodosum and arthralgias. The presence of this is highly suggestive of sarcoid and does not require biopsy diagnosis. Alright, number two, you got amyloidosis. Again, accumulation of things within the heart causing a restrictive physiology and giving you a diastolic heart failure. Then you got hemochromatosis. I've already told you hemochromatosis can give you both dilated cardiomyopathy as well as a restrictive and so a diastolic heart failure. Finally, you got Loeffler's syndrome. Loeffler's syndrome, you don't see it very much in real life, but USMLE likes to ask one or two questions on this. This is basically a child who's having some form of allergic cardiomyopathy, and the key feature you're going to see is the presence of eosinophils. It's an eosinophil induced damage of the cardiac myocytes, which is going to give you something called as Loeffler syndrome and leads to diastolic heart failure. Alright guys, so this is the important thing to remember. There's heart failure, you have to differentiate it into your diastolic heart failure and your systolic heart failure. So we've already gone through all the causes as well as why they really give you heart failure. This concludes the causes of heart failure, and upcoming next is pathophysiology of heart failure. Hey guys, today I'd like to welcome you guys to a video which is dedicated to understanding heart failure. Okay, heart failure is a very high yield topic. Again, a lot of symptoms, a lot of signs that we have to know. I don't want you to memorize anything from today onwards. All you got to do is understand every single step and why that symptom actually develops, because once you understand it, you'll know how to treat it and you'll remember it better. And that's the whole idea of USMLE, is whether you understand it or not. Alright, so let's begin. This is a simple drawing that I'm going to use to explain heart failure and its symptoms. So this is my heart over here. This is the left atrium, left ventricle, right atrium and right ventricle. Okay, so when I say heart failure, essentially what I'm trying to say is the heart has failed. Maybe a systolic problem, maybe a diastolic problem, doesn't matter. For me to understand what the symptoms are, all I need to know the heart has failed as a pump. So for whatever reason it failed as a pump, essentially means it is not going to pump out as much blood as it should. So what am I going to have less of? This is your left ventricle, and I'm going to draw the aorta here. If you have heart failure and you're having less blood pumped out, I can tell that as being decreased cardiac output. Okay, so decreased cardiac output. Now, a lot of people would complain. They're going to come to you and say, oh, I feel fatigued, I feel tired. When I walk, I get exertional dyspnea, exertional fatigue. Why does this happen, right? Think about it. It's not just physiology, it's actually biochemistry when you think about it. If you have a decreased cardiac output, are you going to get enough blood to your tissues? No. Say I'm just going to draw a muscle fiber here. This is muscle, alright? So you have less cardiac output, which means you're going to get decreased blood flowing to your tissues. If you have decreased blood flow, right? If you have decreased blood flow, what happens to the amount of oxygen that you're giving to the tissues? You are going to be giving less oxygen. Okay, if you have less oxygen, what are you going to do? Are you going to do aerobic glycolysis? If you go through your biochemistry, from glucose you get to pyruvate, and from pyruvate, if you have a lot of oxygen, you will convert this to acetyl-CoA and go into your TCA cycle. But what if you don't? What if you don't have enough oxygen? You go the other route, right? You go from pyruvate to produce lactic acid. So this lactic acid, so in this patient with less oxygen, you're going to do more of anaerobic glycolysis, and essentially this is going to lead to, so you'll have anaerobic glycolysis, which is going to lead to production of lactic acid. So lactic acid is the reason behind you having this muscle fatigue and this cramping sensation and all of that. Think about it. If you can actually go out and take a long run, after you run for a long time, don't you feel like there's like ants crawling on your thighs, and you feel like, oh, my legs are getting all cramped up, it's getting tired, it's fatigue? It's all due to lactic acid, guys. And this is the reason why in patients with CHF, they're going to have this exertional fatigue sensation. So that's one explanation for one of your symptoms. Alright, let's keep moving on. Now, exertional dyspnea, right? That's another big one, right? So this guy goes walking and he's not pumping out enough blood, right? If you're not pumping out enough blood because the heart has failed, but your heart is beating faster and faster, what would happen to your pressures within your heart? Your pressures would go up, right? Your blood pressure, your left ventricular pressure is going to go up. Your left atrial pressure is going to go up. And what is connected to your left atrium and the lungs? Your pulmonary veins, right? Pulmonary veins. So what's going to happen is you're going to have a lot of pressure within your pulmonary veins as well. Now, what I'm trying to say is you're going to have a lot of hydrostatic pressure within your blood vessels. So this is your blood vessel and you have a lot of hydrostatic pressure. Increased hydrostatic pressure. What would happen to fluid when you have a lot of hydrostatic pressure within your blood vessel? Would it push it out? Would it push it out of your pulmonary vessels? Yes, it would, right? So you're going to push out a little bit more of fluid from your blood vessels in your lungs. And this is your interstitium of the lungs. And say this is your alveolus here. Alright, so what's going to happen is your interstitium of your lungs are going to become very wet because they got a lot of fluid. There's interstitial edema that happens within your lungs. And tell me, if you have this interstitial edema, would you have efficient gas exchange between your blood vessel and your alveolus? No, you won't. So that's the reason you're going to have exertional dyspnea. Alright, now acutely, another big question people love to ask is, patient comes to you suddenly with sudden shortness of breath, and patient's got very severe shortness of breath, and the guy cannot breathe at all, and his oxygen saturation is going down. Now in these patients, this is more of an acute pulmonary edema presentation. All right, when you say acute pulmonary edema, it's acutely the heart has failed and you have such a sudden rise in pressures within your lungs acutely. That is acute pulmonary edema. Whereas in chronically exertional dyspnea, that's more of pulmonary vascular congestion. All right, pulmonary vascular congestion, exertional dyspnea. Acute pulmonary edema is an acute nature. For whatever reason, the heart takes a hit, and at that point you're going to have acute pulmonary edema. Now when you have acute pulmonary edema, a lot of books love to say pink frothy sputum, right? Pink frothy sputum. Again, let's go back to the same image here. Acutely, if your pressure within your pulmonary vasculature rises, are you going to have a lot of fluid seeping out? Yes, you would, right? A lot of fluid is going to seep out, and so much so it's so high that it's going to be damages to the blood vessels here, and as a result some form of blood tinged fluid gets into the interstitium. Now the difference is it's going to be blood tinged because there's damage to these vessels, right, because of such high pressures, and this is eventually going to lead into your alveolus because the lungs are so wet and filled with fluid. The fluid is actually going to go into the alveolus. Once it goes in the alveolus, you're going to start coughing and you're going to bring out the blood tinged sputum, which is known as pink frothy sputum. All right, pink frothy sputum is seen in acute pulmonary edema. All right, very good. Okay, let's keep going. So now we've already explained exertional fatigue, exertional dyspnea, acute pulmonary edema's beautiful sign, which is known as pink frothy sputum. Okay, let's go on the more chronic run. Somebody's heart is not pumping, you have less blood flow to the rest of the body. Over time, right, what's going to happen is this increased pressures within the pulmonary circulation is going to go to the other side, which is your pulmonary arterial side. Alright, so essentially what's going to happen is you're going to develop something known as pulmonary arterial hypertension. If you want to define pulmonary arterial hypertension, it is a pulmonary arterial pressure greater than 25. Now there's multiple different classes of pulmonary arterial hypertension, which I will tell you at the end of this lecture. Alright, so pulmonary arterial hypertension happens. Once that happens, now your right ventricle is supposed to pump against a very high pressure, and when this happens, what's going to happen is your right ventricle is going to start to fail, right? So once your right ventricle starts to fail, your right atrium will start to fail, and then this is known as right-sided heart failure. So when you think about right-sided heart failure, you get other nice symptoms now. The other symptoms you're going to get is something known as ascites, right? You can have ascites, and you can also have congestive hepatomegaly. The reason is a lot of pressures within your IVC, and all the drainage of blood from the liver is going to go to the IVC, so the back pressure causes hepatomegaly. All right, and you can also get ascites. Again, the reason why you get ascites in hydrostatic in heart failure is because of elevated hydrostatic pressures, guys. This is important. You want to remember, in different types of failures you can get the same presentation, but the reason is different. Okay, in heart failure it's due to elevated hydrostatic pressure. So you have a lot of hydrostatic pressure within these blood vessels, and as a result you're going to end up getting ascites. Alright, when you go down to the legs, you're going to get a pitting pedal edema. Again, why do you get pitting pedal edema? Increased hydrostatic pressure. That's it. It's all tied up to this one little Frank Starling's law. Increased hydrostatic pressure is the reason behind getting pitting pedal edema. Alright, and now I also wanted to tell you about your pulmonary arterial hypertension. There's actually 5 classes of pulmonary arterial hypertension. So the simplest method of remembering it is just follow me right now. I want you to take your hand and place your hand right here. Class 1 is going to be called a pulmonary arterial hypertension. Okay, it is class 1 is going to be called primary pulmonary arterial hypertension. Now you have class 2 3, 4 and 5. Class 2 is due to your left heart. For whatever reason your left heart has failed, you will end up getting class 2 pulmonary hypertension. So class 2 is for left-sided heart failure. If you have a left heart failure, you will have class 2 type of pulmonary hypertension. Now what is class 3? Is both lungs, alright? Both lungs, 2 lungs, you're going to end up having so bilateral lung pathology. Pathology will lead to class 3 pulmonary hypertension. Class 4 is point down. Class 4, when you point down, it is essentially meaning thromboembolism. PEs, chronic PEs, okay? So chronic thromboembolism is class 4, and class 5, like every other thing, is idiopathic. It's unknown, okay? All other causes come here. So idiopathic. So this is how you're going to remember your pulmonary artery hypertension classes. Class 1 is primary pulmonary arterial hypertension. Class 2 is left ventricle, left heart. Class 3 is bilateral lungs. Class 4 is thromboembolism. Class 5 is unknown, okay, or idiopathic. Very good. Alright guys, so I think this explains all that you need to know about the symptomatology of heart failure. Do not have to memorize. All you need to know is understand what the real problem is. Now, also one more point I'd like to add here is if you have a patient who comes to the hospital with acute heart failure symptoms, is admitted for acute exacerbation of congestive heart failure, you will always treat them with IV furosemide, never oral. Ever thought why? Well, I'll explain why. When you have a lot of edema in your body due to increased hydrostatic pressure, would you also have bowel edema? Yes, you would. You will have your intestinal edema. If you have intestinal edema, would you be able to absorb oral furosemide? No, you can't. So that's the reason. That's the reason we're going to use IV furosemide in patients with acute exacerbation of heart failure. Alright guys, I think this ties up everything that you need to know. Thank you for watching. Stay tuned for more upcoming videos.